Hello, good evening, and good day. It's good to be back. It's time for our online patient meeting. I am your host, as always, Caroline, and we have another topic to discuss today. And we have another special guest with us. You can already see this is Dr. Meir Olcha, and it's good to have you with us on board. How are you feeling today?
I'm doing great. Just in case people don't know, I'm you guys all the way from New York City in Manhattan. We have a lovely day out. It's hard to see, but it's a beautiful day, and it's a pleasure to be here. And thank you so much for inviting me to give you a talk about this topic.
Excellent. Thank you so much. And we are definitely happy to have you on board with us. And I just to start off, of course, thanking to our partners and ambassadors. As always, you can see all of them right here on the screen. As always, I want to mention them because, of course, without their help, it would be very hard to simply organize all those events. And, we had plenty of them, and there are still more of those events coming up. All right. And I just want to simply mention that Dr. Meir Olcha, he is actually the gynecologist at New Hope Fertility Center, which is, as he mentioned, is located in New York City. And Dr. Olcha is also a director of pre-implantation embryo assessment. So I am definitely happy to have you with us. And today he will talk about mini IVF, minimal stimulation in IVF, indication, limits, and outcomes, of course. So we will start, as always, with his introduction. Afterwards, we will go for those most common questions, and right there, there will be time for your questions. So as always, remember to put all your questions in the chat section, and we will be showing them one by one, so Dr. Olcha can help you out. So don't miss your chance. Ask away. And well, that is it from me, and I believe we can start. Are you ready to begin?
Sure, yeah. So again, thank you so much for inviting me. It's a real honor to give a talk like this. And I would encourage everyone in the audience to not only come up with any kind of questions about mini, which is the primary topic, but obviously if there's any other questions, even outside the topic, I'm more than happy to give it my best to give you my advice.
Excellent.
My name is Dr. Meir Olcha, and I am a fertility doctor, gynecologist and fertility doctor here in New York City. I actually did my training in the U.S., both medical school residency and then subspecialized in primarily female endocrinology and infertility here in New York as well. And so I've kind of New York raised, I guess you could say, for the vast majority of my medical career. I've been at New Hope for quite some time now, practicing gynecology since I would say 2010 almost. So it's been quite a long time. I've definitely focused my care more towards mini IVF and minimal stimulation over the past few years. And so I'm happy to, give this talk and hopefully give you guys a little bit of insight onto why I really have come to love the mini IVF approach, and why I think that for certain patients and certain populations, the outcomes are potentially better, and also the risks are minimized compared to conventional IVF. I think the only other thing I could say is that, as you mentioned before, I am also the director of pre-implantation embryo assessment, which is sort of just a fancy name of saying that I run our genetics laboratory here at New Hope, and we have our own proprietary genetics platforms that allows us to test embryos for the whole complement of their genes and all of their DNA. And that's kind of the basis of how we can prioritize embryos for transfer and give patients the best outcome. So I think with that, I'm happy to move to the first question.
Excellent. Thank you so much. And let's go with the question. So the first one is, what is minimal stimulation IVF and what are indications to use it?
Sure. So when I think of IVF, conventionally or traditionally, the way IVF is done is that physicians will use primarily injections of hormones to try and stimulate the ovaries to produce lots of eggs or lots of follicles. And so in an in a natural cycle, and it's probably best to go through what a natural cycle is first, and then to kind of move into what IVF is and what conventional stimulation is, and then how that differentiates or how that differs from minimal. So in a natural cycle, your body puts out just a little bit of hormone every day, and that hormone is enough to grow one egg. And typically women will ovulate or grow one follicle and ovulate one egg during that cycle. And so for a typical 28-day cycle, you're growing one follicle. The patient is ovulating around day 14. And ideally, they have intercourse during that time and they're able to get pregnant. But during every month, more than one egg is recruited or wakes up. So there's a whole group of eggs every month that wake up, and as women age, that group of egg gets a little bit smaller in quantity and potentially even smaller in quality. And so the whole point of IVF is to try to exploit that so that we don't just wake up one egg, but we actually wake up and stimulate that entire group. So we make the process of ovulation a little bit more efficient, and that's why the conventional IVF approach was initially developed for. So the idea here is that we are giving excess amounts or super physiological amounts of hormones, traditionally something like FSH or follicle stimulating hormone, which is an injection, potentially along with some other injections like Menopur, which is a combination of FSH and LH, which is luteinizing hormone. And then those high doses of hormones really allow for not just the one egg to grow, but maybe 5 eggs or 10 eggs or the entire group of eggs if possible. And so that's conventional. There are risks to that as well. And so probably the biggest risk is what's called ovarian hyperstimulation syndrome. And that's the most common thing that people get. You often hear stories that someone does an IVF cycle and they're nauseous throughout the cycle and they have vomiting and their belly gets bloated and they have ascites in their belly or buildup of fluid. Their ovaries can twist and torse, and that can lead to problems with blood supply. They develop numerous cysts and they just don't feel well. And that is something that we really don't like. And that's something that we really would love to avoid. And I think that's really what started the whole trend to do minimal stimulation. And so the way you should think about minimal stimulation is we are trying to do a more gentle, controlled, and holistic approach to IVF. We feel that bigger is not always better, that it may not necessarily fit every person to take 10 times the normal hormones and take 3 injections a day. And go through this procedure that puts you at significant risk for hyperstimulation. And so we've, us along with many other centers around the world, especially in Japan, have pioneered this idea of mini-stim, which is let's try and personalize the medicine. Let's try to understand how many follicles the patient actually has and what's the required amount of medication to get them to grow. And in general, a mini-stim protocol is typically a combination of some injectables and then some oral medication to supplement. And it's the combination of the oral medication and the injectables that allows us to really get excellent quality stimulation without the use of these really high conventional doses. And of course, the biggest benefit is that we avoid a lot of these severe side effects that we see with conventional IVF. So that's kind of like in a nutshell, what the difference is between mini stim and conventional stim. Again, we're focusing on quality as opposed to quantity. We're supplementing the injections, or we're reducing the injections and supplementing it with some oral medication, which is certainly easier to take. We can even avoid certain injections like trigger shots. We have various nasal sprays we can do. And lastly, of course, we avoid the high risk of hyperstimulation. So hopefully that kind of gave you a little bit of an answer, sort of as a foundation for what minimal stimulation is and why we use it.
All right. Excellent. Thank you so much for answering the very first question. And let's have a look at the next one. So how many eggs are expected to be frozen with mini IVF?
Yeah, so this is, I would say, right up there with some of the most common questions we get. And it's not as simple of an answer. I think, the real answer is it depends. And it primarily depends on the patient's age and her existing ovarian reserve. But if we focus on sort of our typical patient who's, let's say, 37 or 38 years old with a pretty good ovarian reserve, and maybe the reason she's not pregnant is because there's a sperm quality issue or maybe there's a fallopian tube issue. So overall, we're going to make the assumption that her ovaries are working well. I would say with a mini IVF approach, using a combination of some injectables and some pills, we would probably expect to get something between 6 and 10 eggs from one cycle. But understand that that can vary significantly. We have sometimes patients who are a little bit older, maybe 43 or 44 years old, and they may only have a couple follicles, maybe 2 on the right ovary and 1 on the left ovary. And in that case, whether you give them 600 units of FSH, which is the injectables, or you give them 100 units, the maximum amount of eggs they'll get is what they have. So if you start with 3, that's really kind of the maximum you're going to get. And so that's why using something like an ultra mini or a mini IVF approach is particularly optimistic in these type of situations, because we don't need that excess medication. We just need enough medicine to get those initial eggs to grow. So, the bottom line of how many eggs are expected, I would say in patients who are under the age of 37, 38, maybe somewhere between 6 to 8 eggs or 6 to 10 eggs. And patients who are a little bit older with mini IVF, it may be slightly less, maybe around the 2 to 5 or 2 to 6 eggs.
Perfect. Thank you so much again for explaining all the details on that question. And of course, let's go to the next question. So when will my egg retrieval embryo transfer, frozen embryo transfer, be scheduled?
Yeah, so this is a great question, and it kind of hones into what our protocols are, really. And I like to split, or to make it really kind of simple to understand, I like to split the IVF cycle or the protocol into 4 phases. So we usually do the first phase, which is called preparation, and that happens just before the patient's expected period. So if a patient was to expect their period on June 1st, then we would actually start preparation before June 1st. So maybe May 22nd or May 23rd, sort of towards the tail end of the prior cycle. And that preparation phase lasts for about 7 days, where we usually give them something like a birth control pill in order to help synchronize all follicles so the follicles grow together. So that's 7 days right there. Then what happens, you do the stimulation phase. So now the preparation is over, it's day 1 of your period, and we usually will stimulate for somewhere between 8 to 10 days. And so that brings you up to about day 10 of your or day 10 of your cycle. Some women may need a couple extra days, so maybe day 10 goes to day 11 or day 12. And then at that point, there is going to be a trigger where we want to actually help the follicles mature, so that they're prepared to be retrieved surgically. And that's a trigger that you take at home in the evening. And then 36 hours later, so we went preparation, stimulation, trigger, that's the 3rd one. The 4th phase is egg retrieval, and that happens 36 hours after the trigger typically. So all in all, we're talking about 7 days before your period starts. And then after the period starts, the egg retrievals are usually scheduled somewhere between 12 to 14 days after the period starts.
All right, excellent. Thank you once again for your explanation to this question.
I'm going to add just one last thing.
Yes, true.
Obviously, the point is not just to get eggs, but to get embryos, and just so that everyone's on the same page. What we're really getting at the surgery, we're getting the eggs. And then on that same day we do the egg retrieval, we will take sperm and we'll fertilize the egg with sperm if you're doing, if you want to generate embryos. And then we allow those embryos now to grow for anywhere between 5 to 7 in the incubator. And at that point, they're frozen. And that really kind of ends the cycle. For the patient, the cycle ends the day of the egg retrieval. There's really nothing else to do after that. But for the entire cycle and the protocol, that ends about 6 to 7 days later, because it takes some time to grow those embryos in the incubator.
All right, excellent. Thank you so much. I just want to make sure that can you hear Dr. Olcha? Okay, because I knew that some voice has been breaking up for you. So, oh yes, okay. Um, you can hear okay. All right. So let's try once again. I just want to make sure that everyone can hear you properly. Okay, because now let's see. Okay, if not, we will disappear for like 1 minute to see if we can fix this, but let's go ahead to the next question to see if it's now better. Okay,
Sure. I mean, hopefully everyone can hear me right now.
now it's actually a lot better, so I
Okay.
guess it was just for a few minutes like this. Okay,
So,
so why do I need to take oral contraceptive pill?
yeah, so that's a great question. And that's kind of what I alluded to when we talked about those 4 phases. That very first phase is preparation. And we have to remember that when women go through cycle after cycle, their body really only wants to ovulate one egg. Their body wants to select one egg to ovulate. And what we are trying to do is exploit their body a little bit and select more than one egg to grow. And that's where the birth control pill comes in. I won't say that it's a requirement, but it's definitely highly recommended because when we give a patient some birth control just before her cycle is expected to start, what that does is it kind of suppresses the brain a little bit and it allows all of the follicles to synchronize. It's kind of like a race. So you want all the runners to start on the same starting line. If you have a runner that is already a kilometer ahead, then by the time you're ready to retrieve those eggs, that first egg that was bigger is going to be ready for retrieval, and you'll only be able to get one egg out of the cycle. But by taking a little bit of birth control pill, and I'm not talking about a month, but literally 5 to 7 days, what we can do is we can synchronize all the follicles so that when we're ready to start phase 2, which is the stimulation portion, they all grow equally together. And so that's why it's very important. I will add that there are patients that, for whatever reason, don't want to take a birth control pill or can't for some medical reasons. And that's totally okay too. But it does mean that just before we start the IVF cycle, we want to make sure that all the follicles are indeed the same size and that the hormone levels, particularly estrogen levels, are nice and low, ideally below the 85 range.
And excellent. Thank you so much once again for your explanation. And well, let's go to the next question. So, how many embryos should I test?
Yeah, so this is a great question. And I think that part of this really is a personal choice. And then there is some sort of medical opinions that you'll read here and there. When we test embryos, we have to remember that we are not changing embryos. We're not taking a good embryo and making it bad. We also can't, unfortunately, take a bad embryo and make it good. So the embryos are the embryos. That's the way they were made, and there's really nothing we can do to change that. However, what we can do is we can try and better select an embryo so that the likelihood of pregnancy or the chance that will be successful is higher from the start. And so a good example is, well, what if someone has 6 embryos? How do you know which one to put in? We don't want to put all 6 in because they might get triplets or quadruplets. So we want to for sure avoid that. So how do you know which one to put in? One way we used to do it in the past is we would look at the embryos under the microscope and we would grade them and we would say, okay, this embryo looks really pretty, that's a grade A. And embryo number 2 looks just so-so, that's a grade B. And embryo number 3, that looks really bad. The cells are not even, they're not synchronous, the inner cell mass doesn't look constrained to one side, and so that's a grade C. And in the past, we would transfer the embryo based on the grading. But what we know today is that the embryo grading does not always predict success. So you could have a grade A embryo, a beautiful 5AA embryo. It's a nice blastocyst. but it could have Down syndrome. And that would be really bad. And we want to avoid that. You could have a really nice embryo and it could just not implant. And so that's where testing comes in play. It's when a patient has a group of embryos, 4, 5, 6 embryos, for example, and they'd like to get pregnant and they'd like their first try to be the best shot. And so that's where we will test the embryos for genetics, and we'll use a combination of not just the grading, but also the genetics to select which embryo to put in. And that will increase our per transfer pregnancy rate significantly, because we are not just randomly picking embryos, we're picking embryos that have the highest chance of getting pregnant. So how many embryos you should test? In an ideal situation, you test all of them. But we know that testing embryos is expensive, it's time consuming, there's quite a lot of financial implications, and so you should test where you're able to test. And I often tell patients that if you could, in an ideal situation, sure, if you had 5 embryos, I would test all 5. But again, just remember that testing doesn't change and make an embryo good. If it was meant to be good, it's good. So you should do what you're comfortable with.
Fantastic. Thank you once again for answering and explaining this question. Now we will go for the last question when it comes to those most common ones. And of course, then it will be time for your questions. And I do see some of the questions ready as well. The question is, so does my partner need to take antibiotics?
Yeah, so, I would say there is no standard of care, at least not in the US, about whether a partner needs to take antibiotics just before a cycle. Probably the most common antibiotic that's given to men is something called doxycycline. And it's thought that if there's a small, undetected asymptomatic bacterial infection in the sperm, it could affect fertilization rate, it could affect the quality of the embryo. What I would say to that is there isn't any great conclusive evidence, and we can even see that in the various practice patterns. So some IVF centers in the US, they just mandatory. Their protocol is that all partners take antibiotics. Here at New Hope, that's not something that we will say that is mandatory. If there is a history of infection in the male partner, for sure, we would take it. If there is some issue with fertilization, or we look at the embryo dishes and there's bacteria on them, or there's bacteria in the sperm, then yes, we would give them antibiotics. But we don't routinely give all partners antibiotics unless there's some other medical indication.
Excellent. Thank you so much for answering all those questions on our topic, of course. And now it is time for the questions from our patients. So, Dr. Olcha, are you ready for them?
Let's go.
Excellent. And so let's start with the very first question that we have right here. I am 38 with a very low egg reserve, AMH 0.4, FSH 14, AFC2. What protocol would you ordinarily recommend?
All right. Well, thank you, Victoria, for giving that question. I would say that you are probably one of the most common patients we see at New Hope. By far, the vast majority of patients we see are those that have gone to other centers and have failed. And they failed because a conventional protocol, in honest opinion, is not appropriate for someone in your situation. Remember, you're at a point where you've got 1 or 2 follicles, maybe 3 follicles. Whether we give you 600 units of injectables, which is full stimulation, or we give you minimal stimulation, the maximum eggs that you'll probably achieve in that one cycle is what your antral follicle count is, which is 2, maybe 3. And so what I would say is I would tailor a protocol to that. Your FSH is already a little bit high. It's already 14. That's plenty of FSH to have some good follicular growth. So in this case, New Hope, we have a protocol called an ultra mini protocol where really it requires no injections. And I think that whether you take high dose injections or you do an ultra mini protocol where you really just take some tablets, a combination of probably Clomid and Letrozole, you would have very similar outcome. And in fact, you may even have a better outcome with an ultra mini protocol because we have less outside injections, which we know could affect the quality of eggs. So I would probably say stick to something like an ultra mini protocol. I don't know that you would really require any injections. If it turns out that after a few days of stimulation, there's 3 or 4 extra follicles that kind of popped up, then maybe we would add a very small dose of injections. But I would say probably a very minimal ultra mini protocol, and you would do just fine.
And thank you so much for the very first question and your assistance, your help with it as well, of course. All right, there are more questions, of course, coming up. The next one is right here. Some say that high doses of gonadotropins compromise egg quality. Is that true?
Yeah, so that's a great question. I just want to make sure that everyone can still hear me. Can you hear me still okay?
Now everything is okay. For me, for sure. I believe, yes, for the patients as well. Thank you for checking. All is okay.
Okay, great. So, there's some data on this, but unfortunately, a lot of the data is what I would call sort of grade B or grade C data. It's what we call retrospective data. Unfortunately, it's not so easy to give someone high doses of gonadotropins, see what their egg quality looks like, then go back in time and not give them those high doses, and then give them lower doses and see if there's a difference, right? Because right now we don't have the technology to go back in time, unfortunately. The alternative is to do what's called a randomized clinical control trial, which is where you randomize 2 groups of patients. So maybe you blindly pick 50 people in one group and another 50 people in the second group. You make sure that their ages are similar. You make sure that their ovarian reserve is similar so that you're dealing with a similar population. And then you give some of them low doses and some of them high doses. And you look at various factors that are associated with egg quality. And unfortunately, a really good controlled study like that just has not been done. There are, however, some retrospective studies where they look at a whole group of patients, but they're different, right? Everyone's different from each other. And some got lower stim and some got higher stim. And there's some evidence there that that potentially lowering the dose of gonadotropins, especially in patients with diminished reserve, could improve egg quality. And so I am a believer in some of that data. Is it the best data in the world? No. Would I love to see better data? Absolutely, but it is what we have. And I do think that for certain patients, again, especially those ones that have diminished reserve, these really doses of gonadotropins probably are not particularly beneficial.
All right, understood. Of course, thank you so much for this question indeed, as well as your answer. Okay, and next question is also ready. So how many eggs are expected for normal IVF? Can you hear me?
Seems like I'm not sure if we're having some connection issues or not.
Can you
I
hear
hope
me
it's not
right
on my
now?
end.
Can you hear me?
Oh, sorry about that. Okay, great. So the question is how many eggs are expected? Is that right?
Yes. Can you hear me? All is okay?
Yeah. Yep,
All
we're
right.
good.
Go ahead.
So, I think I touched based on that a little bit. It's very hard to kind of give a set number because everyone is a little bit different. So, going back to that example where we have a patient who's 37 or 38 years old with a pretty good reserve, I would say with a conventional IVF, you should probably get somewhere between 12 to 14 eggs. But again, that comes with the risk of some ovarian hyperstimulation, which is some of the things we talked about: the nausea, the vomiting, the weight gain, the water gain, the abdominal distension, and the bloating. Whereas from a mini IVF, we might expect more kind of like an 8 to 10 or 6 to 8. And what we're really banking on here is quality versus quantity. And so we're allowing the body to kind of select out those bad eggs and only allow the good eggs to grow.
And again, thank you so much for your explanation to this question. And now let's have a look at the next question. So, can you recommend too many IVF in a row? Would you suggest a break in between? How about if you would do one mini IVF first and freeze all, and then go straight to a normal stimulation IVF with your following cycle?
Yeah, I would say that um, sometimes it's good to take a little bit of a break, not just for your kind of physical body, but also for some emotional break. IVF is not an easy process to go through. There are financial implications, there's psychological implications, there's emotional implications, there's family implications, there's time constraints. So, aside from the medical reason, there's lots of other reasons why some people take breaks. I think that it's perfectly safe to do three or four cycles in a row. I don't think that there's ever been any good data or any paper published that shows that that's dangerous. Except again that some people do need a mental break, and sometimes it's a good thing. You kind of you grasp you get a hold of the ground again. You're able to kind of look at the past, you're able to tweak the cycles a little bit, and then prepare yourself again for the future. And it's okay to switch between mini and then go into a normal stimulation. In fact, many patients do that. Sometimes we'll do a mini cycle and then we'll do a conventional. Sometimes we'll start with a conventional IVF and then do a mini if the conventional didn't work very well. So, I can't really speak to other IVF centers, but we are definitely very dynamic here and we personalize care. So we don't have one specific protocol that we push on everyone. We really kind of look at the whole picture, look at the patient, look at her antral follicle count, her day 3 labs, what kind of cycles has she done in the past, if that's applicable, and we go from there and we try to really really personalize that care on an individual basis.
Okay, excellent. Thank you so much again for providing all the details to this question as well. Next one also is right here. I am 37. I have had 2 failed IVF cycles, 4 eggs retrieved first cycle, 1 egg was empty and 3 immature eggs. Second round, 4 eggs retrieved, only 1 egg matured and fertilized and saw 1 embryo transferred, but no implementation. What protocol would you recommend for next round?
Yeah, so when I hear stories about how either we have empty follicles or immature eggs, I often think that there could be issues with the timing of the trigger. That's probably the number one answer there. And then the second thing to look at is the type of trigger that was used. So it may not necessarily be the protocol. The fact that you're 37 and you're very young, that actually goes to your favor. The fact that only 4, I'm assuming you mean follicles were developed, that's not so great because we would expect for a 37-year-old, again, something more towards, 10 follicles, especially if this was a conventional IVF cycle. So there's clearly some innate, diminished ovarian reserve there, and that's okay. We can work around that. But when I hear that 1 egg or 1 follicle was empty and that there were some immature eggs, one thing that could lead to it is timing. So perhaps they didn't allow the follicles to get big enough if you were triggered a little bit early. Another thing is that maybe there were some bigger follicles and some smaller follicles. So there was the cohort was not aligned. The eggs were not really synchronized. And so we'd really want to try and synchronize them to make sure that they grow equally. And then the last thing is really the type of trigger. And I don't know exactly what kind of trigger you used. The most common trigger is either a Lupron trigger or an HCG trigger. But when I hear about immature or maturity issues, I often will do a dual trigger where the patients get a little bit of Lupron or LH surge, and then they also get a little bit of HCG. And typically the combination of both of those together, along with adjusting the timing, prevents maturity issues.
All right. Again, thank you so much for providing the details to this as well question. Okay, next one is also ready. I have diminished reserve. My AFC at baseline is always between 6-9, depending the month, and it's important for me to try to get as many of those follicles as possible. The max I have ever gotten at egg retrieval is 7. I tried some variation of mini IVF twice, but the numbers weren't good. 4 retrieved, then only 1. Is it still worth doing? I also have an issue with asynchronous follicle growth.
Sure. So, unfortunately with IVF, there's always this drop down, and there's a ceiling. So if the antral follicle count in the beginning of the month is really around 6 or 7, like I mentioned before, that's really going to be the maximum follicles that you can get. Occasionally there are some smaller follicles that are missed, and so we have patients where their antral follicle count is 6, but they end up getting 8 eggs. I mean, that's very much kind of within the range of, I would say, a 20% plus or minus. If we're talking about asynchronous follicle growth, one thing I would recommend is trying some type of preparation, either birth control preparation, or sometimes if there's a component of diminished reserve, which it sounds like there may be, I would try an estrase preparation, which is estradiol. It's typically dosed at 2 milligrams, and it's given at the same time, 7 days before your expected cycle. And the reason I mention estradiol or estrase preparation as opposed to a birth control is because there's some recent data that has shown that especially in women with diminished reserve, an estrase preparation helps kind of prepare those follicles to accept a good stimulation. It gets their FS receptors running, and they tend to stimulate better. Why you got 4 retrieved the first time and only 1 the second time, that could just be cycle to cycle variation. It could be maybe the protocol was changed a little bit. It could be something in terms of the retrieval and how the retrieval was done. Maybe there were some complications with the location of the ovaries. That oftentimes happens where in one cycle, the ovaries are both very accessible, but the second cycle, one ovary is not so accessible, so it makes retrieving the eggs a little bit more difficult. And is it worth trying again? It sounds like you are developing follicles. It sounds like you're getting eggs. So I would say, yeah, it's probably worth trying again.
All right. Again, thank you so much for your question and your advice to this as well. Okay, next question is also ready. So what are the success rates compared to normal IVF? Both of our results have come back normal and healthy, so our infertility is unexplained. So we are wondering whether this is the best option for us versus traditional IVF.
Yeah, so I would say, about 10% of women or 10% of couples really fall into this category called unexplained infertility. It's a very frustrating category to be in because it means that we've looked all over and we've used all the tools and the instruments and the tests that we have, and we know something is wrong, but we can't figure out what is wrong. And we are getting better and better in the fertility field at being good diagnosticians, and there are lots of new and emerging tests that have come out, whether it's genetic-based tests or endometrial tests that can kind of help explain some infertility issues. But inevitably, couples fall into this category of unexplained. The success rate for patients with unexplained varies, and it's slightly lower than perhaps some of the other fertility or infertility categories. We typically quote, again, at least looking at US data in terms of IVF, the success rate per cycle should still be something around 25%. But what I can tell you is when I have patients with unexplained infertility and they get a normal embryo, the success rate is not much different. So here at New Hope, when we transfer one single normal embryo, the success rate is about 65%, which is pretty good. And that doesn't change whether your diagnosis is unexplained or your diagnosis is tubal factor or male factor, for example.
All right. Again, thank you so much for answering this question. And next one is this. Why does taking the pill make the corpus luteum go away?
So, it's a little bit of a myth. Taking the pill does not make the corpus luteum go away. It will probably go away on its own. The reason that birth control pills work very well is that they prevent new cysts from forming. And so the pill itself won't make the existing corpus luteum go away any faster, but what it will do is it will prevent new cysts from coming up. So this way, if you do another ultrasound in a month, that existing corpus luteum is gone and you don't have a new one that's there because that birth control pill has really suppressed the brain. So it's a little bit of a myth, but it's a very common one. And usually what people tell me is that they get a lot of cysts in their ovaries, and so they heard that taking birth control pills make the cysts go away. Again, it's just a bit of a myth. They don't make the cysts go away any faster. They just prevent new cysts from forming, and therefore, when you get an ultrasound a month later, there's no cysts. So that's kind of the way it works.
All right, thank you so much. And there is a follow-up from the very same patient. Okay, so let me go to that one. So should my donor still go ahead with an IVF cycle, then even if she still has the corpus luteum?
Should my donor still go ahead with an IVF cycle even if she still has a corpus luteum? You know, what I would say is if there's still a corpus luteum and the progesterone level is elevated, then you may want to wait for that progesterone to come down. If there is a cyst that's there at the baseline and the progesterone is low, as long as the estrogen is equally, in the low range, less than 85 here in US units, then I think it's pretty much safe to go ahead. And I don't foresee that being a big problem. It's probably just, a metabolically inactive cyst.
And again, thank you so much for answering yet another question. And now let's go to the next one. Okay, maybe you know it. Are there any clinics in London, UK that you personally know of and would recommend?
I wish I could give you one off the top of my head. I don't have them, but we do have a department here that deals a lot with what we call outside monitoring, and we have a whole list of clinics all around the world that we've been happy where we've sent our patients there, and I'm sure that we have some London clinics listed. So if that is something that you seriously want to get some recommendations on, perhaps we can send some information out later after this.
All right, of course. Thank you so much for that as well. Okay, next question. So in mini IVF, will the quality of embryos, will it be better?
Yeah, so the quality of embryos, it's not really dependent on just one variable, unfortunately. The quality of embryos depends on the patient's age, the quality of her eggs primarily. It also depends on the quality of the sperm, and it depends on the quality of the lab, and what type of protocols and what type of embryology culture medium they use, and how frequently they open the incubators, and how well they are at making sure that the embryos are growing according to protocol and that all the various parameters of the incubators are maintained appropriately. But if we were to say all else being equal to patients, everything being equal with those patients, then I would say that probably the quality of embryos in mini IVF is slightly better. And that's primarily because we're not using as much medication and we're allowing the body to self-select eggs as opposed to kind of telling the body, push all the eggs to grow. The good eggs, the bad eggs, just push everything to grow. With mini IVF, we're allowing the body some of its natural tendencies to select the better quality eggs.
All right. Thank you so much again for that. Okay, and let's have a look at the next question. Would you allow Chinese herbal medicine with a Clomid IVF?
Yeah, I mean, absolutely. We see quite a bit of patients from China, actually, and they oftentimes will ask us the same kind of question. I think that as long as the medication doesn't contain any specific hormones that would alter our test, then I think it's totally okay to add or supplement the IVF cycle with herbal medicine. And I would even add that we are real believers in other modalities such as acupuncture, and there's been some pretty good literature to support the use of acupuncture not only during the IVF cycle to improve the blood flow to the ovaries, but also during a transfer cycle to improve the blood flow to the uterus and hopefully improve success rates.
Excellent. Thank you so much again for clarification to this question. Next question is, how many embryos can I get from 8 mature oocytes?
What I would say is it's age dependent. But again, going to that 37, 38-year-old patient, from 8 mature eggs, we would probably expect something like 90% of a fertilization rate. So that would bring you to seven fertilized eggs. And then from there, if we're talking about day 5 blastocyst, we would probably expect something like a 50% blast rate. That would be, standard. And so maybe something around 3 or 4 embryos from 8 mature oocytes. Again, presuming everything I said is the same, that you're young, healthy, good ovarian reserve. The older the patients are, the percent of embryos that lead to full day 5, day 6 blasts goes down. So just to give you another scenario, if you are 44 years old and you have 8 mature oocytes and they were frozen at that time, they were frozen when you're 44, the chance of a blast is about 20%. So from 8 eggs, you're looking at something like 1 or 2. From donor eggs, I can see that popped up right there, then the blast rate should be about 50%. So for someone who's young and healthy, 8 mature donor eggs, that should get you roughly 3 to 4 blasts or 3 to 4 embryos.
All right, excellent. Thank you once more for that. Okay, next question is also ready. And let me just show you. Okay, here it is. I'm 45, first round of IVF with 300 units of gonal F, short protocol, only retrieved on 1 egg, which fertilized and was transferred as a 3AB 5-day blastocyst but didn't progress. Would mini IVF possibly retrieve more eggs? Follicle count this month was 8.
The answer to that is it maybe. It may actually lead to more eggs. And it depends what your FSH is. So if you're 45 and your FSH is fairly high on your baseline, maybe your FSH is 15 or 16, then your body is really pumping out quite a bit of FSH. And it's so much stimulation that it's actually becoming inhibitory. And so that's really where IVF kind of shines, or mini IVF shines, because what we can do is we can prepare your body, we can drop your FSH, kind of go through this withdrawal period, and then slowly trickle back the FSH, but keep it in a very narrow controlled window so that we're not overstimulating. Another way that I like to use, or another example I use, is kind of like a car. So sometimes you get into a car, and if the engine is not so strong, if the engine's a little bit older and it's weaker, then right here you see your FSH was 15, so that's kind of high. So if the engine's a little weaker and you push on the gas pedal, maybe you go, and if you really push the gas pedal all the time and you're flooring it, you've got the gas pedal all the way down to the floor, the engine sometimes just shuts down. It can't handle it. So in that situation, probably a protocol such as like a mini stim that allows you to slowly stimulate the ovaries and really push them to grow a little bit further before you trigger, that might get you a better outcome.
All right, excellent. Thank you so much once again for that advice. Okay, now we do have a bit of a longer question. Okay, so let's have a look at it.
Sure.
How do you recommend patients can try and improve egg quality ahead of IVF treatment? Also, although I have low ovarian reserve, I did fall pregnant naturally 3 times in 2018, but sadly all ended in miscarriage. I know my chance of finding a good embryo due to egg quality are quite low, but I'm keen to try with my own eggs. I know usually IUI isn't recommended for people with diminished ovarian reserve, but as I have felt pregnant naturally, would I be more likely to fall pregnant with some stimulated IUI than somebody else that has never been able to?
Yeah. So I think, the real heart of this is to try to figure out, why did the pregnancies end in a miscarriage 3 times in a row? By definition, that puts you in a category called recurrent pregnancy loss. And therefore, your problem may not be getting pregnant, but your problem is staying pregnant. And so there's a whole recurrent pregnancy loss workup that we would recommend. And part of that is looking at some hormonal issues. Part of that is looking at the uterus. part of it's looking to see, is your body attacking the pregnancy? Is that what's happening? And so, that's something we should look into. I see here that you mentioned that one of them was Edwards syndrome. So that's a classic chromosome abnormality. And that brings me to the second point, which is by far most pregnancies that end in a miscarriage in the first trimester, it's due to some chromosomal issue, which is an egg quality issue. It's exactly what you're alluding to here. And so the way to avoid that is to test the embryos and put back a genetically normal embryo. That's kind of the only real way. And there's plenty of papers that have been published on PGTA testing or pre-implantation genetic testing. And for sure, one of the things that it does the best is lower the miscarriage rate. And it lowers the miscarriage rate because in your case, rather than putting back 3 embryos of unknown genetic quality, we would put back 1 embryo of known good genetic quality. The tricky part is, can you get a good genetic quality egg? And that's going to be the toughest hurdle to get to. There are some treatments that some patients use, and there are some that have been studied. And the 2 most common supplements that have data on them are DHEA, which is a type of male hormone, but seems to improve egg quality in women. And the second one is another supplement that you could buy over the counter called coenzyme Q10, both of which have led to improved egg quality in patients with diminished ovarian reserve.
And once again, thank you so much for that advice. Definitely useful, and the patient already would like to thank you indeed.
You're welcome.
All right, thank you so much. And let's have a look at the next question. And it's right here. So, would you recommend DHEA supplementation to improve egg quality before IVF treatment?
Yeah, so that's kind of just what we talked about. It's a supplement that is a derivative of testosterone. It has been shown in numerous trials to help improve egg quality. Most of the time here in the US, we start at about 25 milligrams. That's a single tablet. And then we work our way up to 2 tablets a day, and then a maximum of 3 tablets a day, or 75 milligrams a day. And ideally, you do this for 6 weeks before starting the IVF cycle. So it does kind of delay you for about a month. But typically what we do with our patients is, if they really have diminished reserve, we'll start them on some DHEA, and we'll go right ahead into the cycle. And hopefully by the time they're ready for the egg retrieval, they're at least 4 to 6 weeks in.
Okay, excellent. And there's actually another question on that. Does DHEA counteract letrozole, or is it okay to take together?
Yeah, it's completely okay to take together. Letrozole, also called Femara, is it's a drug that inhibits an enzyme called aromatase. So it's called an aromatase inhibitor, and that basically what that does, it prevents testosterone from being converted into estrogen. So it prevents estrogen production. And in doing so, it increases the level of FSH in the body. But there's really no interaction between those two, so it's perfectly safe to take together.
All right, excellent. Thank you so much once again. And the question is also, those supplements you mentioned, are they also used worthwhile for women who do not have diminished ovarian reserve?
Yeah, so there isn't data to support the use of them without diminished ovarian reserve. I'm not sure that's recommended. It's not a standard of care. I doubt that it would be harmful, so I don't think you're causing any harm to yourself, except, of course, for the financial implication of it. But I'm not sure that there would be much benefit.
Okay, understood, of course. Okay, and also one more. When should you stop taking DHEA when starting a treatment cycle?
There's a couple of reasons that you want to stop. First and foremost is if you're symptomatic. So if you start getting hot flushes or heat waves, or you develop nausea, vomiting, headaches, then you should stop it, because you're just not responding well to it. Another reason to stop it is if you're going to do a transfer cycle. So if you're done with your treatment and you've already produced follicles and eggs, and now you have embryos and you're ready to continue to transfer, then you should definitely stop the DHEA. You should not be on that while you're trying to actually get pregnant.
All right, excellent. Thank you so much. There are like few questions left, so we will be slowly finishing. So if you have any questions left, this will be the final call. So go ahead and type those in. And let me show you the next question. I am 37 with an AMH of 0.5. My right ovary has been removed because of borderline tumor. I had one failed IVF and I am worried as I am planning a second. Am I at high risk with the hormonal stimulation to get another tumor?
Yeah, this is this is a very tricky case. So borderline tumors, they're called borderline because they are not considered to be fully malignant. It's not a full ovarian cancer. But there's something in the tissue and the pathology that they looked at that make them worry. And patients with borderline tumors of the ovary, they can develop a second tumor, and that can be completely independent of any kind of stimulation. So that's just something to keep in mind. I would say there aren't enough patients out there that have had borderline tumors and are doing IVF. But from the data and from the knowledge that we have, and given the types of medications that we use in IVF, which is primarily FSH, which is something that your body makes anyways, there really shouldn't be a huge risk to stimulation in terms of getting another tumor. The issue here is now that you're down to one ovary, and we should try and do everything possible to keep that ovary so that you don't go into early menopause. And that's a tough situation. So I really, I feel for you. And what I would say is I wouldn't particularly worry too much if you had to do 1 or 2 IVF cycles. The stimulation really shouldn't cause the tumor to grow. And I think you should be okay.
All right. Thank you again for reassuring and well, fingers crossed, indeed, for sure. Okay, thank you so much. And let me go back to the previous question. Okay, so when should you stop taking the HEA? It's about from the same patient. What if it's just an egg retrieval?
So I guess just so I understand correctly, it sounds like you're doing an egg retrieval cycle, and I would say if the plan is to continue to do another egg retrieval cycle, I would continue the DHEA. But if the plan is to stop, then yes, then there's really no additional benefit to taking more DHEA.
Okay, and when we are talking still about DHEA, there's another question. Before embarking on taking DHEA, should I check baseline levels?
I mean, you can do it. It's not our standard protocol to do it here. For sure, the levels will go up after you start taking it, so don't be shocked at that. I wouldn't make a big deal out of it. Most patients, they should not have high DHEA levels, except in very certain particular situations. Probably the most common being something like PCOS or polycystic ovarian syndrome. Another situation would be something really, really rare, like an adrenal tumor or a testosterone-producing tumor. But those are some really rare situations. So, unless you have PCOS, there's no clear indication to check a DHEA baseline level.
Okay, thank you for the clarification once more. Okay, next question is here. Thank you. Yes, I did try estradiol pre-treatment, also called estrogen priming, I think, and it did seem to help. I am hesitant to use the BC pill as I don't want to suppress my ovaries further if I already have low reserve. Is 2 milligrams estradiol 7 days before starting stims, pills, patches, or shots?
Yeah, so you're right. This is called estradiol priming. It's just another name for it. 2 milligrams daily for 7 days is a very common traditional dose. It should not suppress you too much. Alternatively, you could use patches. Typically, we use 0.1 milligram patches, and we give 1 patch every other day. I try to stay away from shots. There is a shot called estradiol valerate. And it's just not necessary to give yourself an invasive injection when there are other forms of estrogen available. And so I would probably either stick with the pills or the patches, and both of those doses sound good to me.
All right. Thank you for this once again. And well, next question is, so what estrogen units do you use in the US?
We use picograms per milliliter or picograms per deciliter. I know some countries use picomoles or p moles, and so the conversion is a little bit different. We do have quite a few patients from the UK who start their cycles there, and then when they're ready for their actual procedure, they fly over here. But as long as you send us the reports, we'll make sure that we convert the units correctly. Certainly, again, I can only speak for New Hope Fertility, but we have an entire department that's dedicated to patients outside of the U.S., and they're very good about that.
All right. Again, thanks so much for this. Okay, next question is, so can I do mock cycle even though I don't have a cycle?
So I think what we're talking about here is a mock transfer cycle. That's typically how we use that terminology. And the answer is not really. I mean, it depends what you're trying to get out of it. So if you're trying to see how thick the lining is, then no. I mean, you have to have a cycle, either a natural cycle or an estrogen-induced cycle. If the goal is to see if the transfer will be smooth, meaning if the actual physical procedure of putting the catheter in and getting the embryo in the right place, if that's the goal to make sure that goes well, then yes, then you don't need to have a cycle. And in fact, you can come in anytime and you can do what's called a mock transfer.
Okay, understood, of course. Thank you so much again. Just checking. Yeah, okay, sorry. Next question is also ready here. In mini IVF, can I ask what dose of pills, Clomid, letrozole, you give? High dose, example, 100 milligrams Clomid, 7.5 milligrams letrozole, or lower doses? And what's the max dose of injections you'd give if any augmentation was needed? Example, 75, 150, 225?
Yeah, so, as I mentioned, we really personalize our care. So we don't have one simple protocol that we use for everyone. We use a variety of factors. If you'd like to know probably what's the most common protocol is probably something like 100 milligrams of Clomid and 5 milligrams of letrozole to start with. And if we're going to add back some injections, probably 75 units a day is the most common. But we tailor that up and down as we need to.
Okay, excellent. Thank you for the clarification once more. There are like 3 questions left, okay, and we will be finishing. So next question is, so would you let someone with low testosterone to go ahead with an IVF cycle, or would you fix it first? The HEA didn't raise it that much.
Yeah, I probably would not fix it. I would let you go right into an IVF cycle. There's probably very little benefit to measuring a testosterone level. I will also tell you that testosterone assays are notoriously not reliable, and so I wouldn't take too much of that.
All right, thank you once again, guys. Okay, next question is also ready. I am 44 with AMH of 0.02. I have been taking the HEA and coenzyme Q10 since 4 months. Do you think it will change anything at all?
Right. Well, this is kind of what I alluded to before. I almost never tell anyone to take DHEA and CoQ10 for 2, 3, 4 months and then come back. That's probably not the best idea. If anything, we tell them start the DHEA and the CoQ10 and start your IVF right away, because every month that goes by, your AMH is going to drop and drop and drop. The number and the quality of follicles will drop and drop and drop. And so I would rather you do them simultaneously as opposed to trying to really optimize everything up front, because age at the end of the day is going to be the biggest factor here.
Okay, of course. Thank you again for that advice. And well, it looks like this will be our last question for today. So let's have a look. It's actually in regards to DHEA. So how does DHEA benefits the cycle in diminished ovarian reserve patients?
This is becoming such a common question. I'm really impressed. A lot of our users here have done their homework.
Indeed, that's for sure.
So, I think the true answer to this, no one really knows exactly why. But it seems that just like estrogen priming improves the follicle's ability to respond to FSH, seems that something probably similar is happening where we're giving this hormone called DHEA, which is a testosterone derivative. It looks very similar to estrogen, with the exception of a couple carbon moieties there. And it probably just improves the follicle's response to FSH. And so having DHEA on board probably improves the ability for that follicle to grow. And then, of course, some evidence that it also improves the metabolism within the follicle. Ideally, hopefully, getting a better quality egg and getting the egg and the sperm to meet better, or to produce a better embryo. But the true answer, I don't think anyone really knows. These are a lot of hypotheses that you read in articles and journals, but we do seem to see that there is a benefit to it.
All right, excellent. Thank you so much. And one more actually showed up just now. And how about coenzyme Q10 then?
Yeah, so coenzyme Q10 it's another one of those cofactors that various enzymes in the cells use, and so when the cell is combining with the sperm and it's trying to segregate that DNA and make sure that the right amount of DNA and chromosomes are going to the right spots, I think things like coenzyme Q10 and other cofactors in the body really help sort of just support cell growth and support the division of the cells.
Take a look, and if you can take a look, what dose do you indicate?
I couldn't tell you the dose off the top of my head, but I'm sure that's something that we can provide later. I'd have to look at what our protocol is here. I couldn't tell you the dose off the top of my head.
No problem, of course. Thank you so much. Remember that I will send you a link in a few minutes, and that way you will be able to simply get in touch with Dr. Olcha and his team, and I'm sure they will be happy to provide you with some more details indeed as well. And as I mentioned, we will be finishing for today. So thank you so much, everyone, for joining us today for all of those interesting questions. I am sure that the answers from Dr. Olcha were very, very useful. Thank you so much for joining us and for your expertise. It's been a pleasure to have you for sure. And I just want you to see that there are many, many thank yous from our patients to you as well.
Thank you so much. And, it's really been an honor to be able to give a talk here, and hopefully I was able to help out answer some of those questions. So thank you so much, and thank you to everyone, and really wish everyone who attended this really the best of luck. Obviously, if anyone wants to reach out to us, I'm more than happy to chat with you.
Excellent. Exactly. I can only encourage everyone to do that. And just so you know, there are more of those coming. Very knowledgeable and articulate doctor. So
thank you.
Couldn't agree more, for sure. So thank you once again. And well, I just want to mention that, to remember, this has been recorded. So if you missed the first part or anything at all, you will be able to rewatch this again. And I can only encourage you to join us at 8 p.m. UK time. We have another very interesting topic and another very interesting expert with us. So hope to see you there. Thank you so much. Have a lovely evening, everyone. Thank you. Bye.
Take care. Bye-bye.
Thank you. Bye.